I'll ask everybody to put on their camera. You take one screenshot so we can post it in the group.
Sure,
It will
ma'am.
start motivating people to come and join us.
Sure, ma'am.
Yeah.
Title Oxy Uniform Cons.
So we are live now. Requesting everyone to switch on their video.
We can start?
Advice or mention.
Yes, ma'am.
Yeah, go ahead.
The time of preparing or discuss. So
Purnima, all the best. This is the first journal club for the year, and it's a very nice topic. I'm very happy that Sushma and Purnima have come together to put this after a lot of push and pull. And so from now on, I think we should be regular and do the programs well. All the best. Do well, Purnima.
Thank you, ma'am.
All the best, Purni. Do well.
Thank you. I'm very happy to introduce Dr. Purnima, who has done MBBS from Hubli Medical College and post-graduation from Bangalore Medical College. And she is the present secretary of IMA Women's Wing Hosur present. And she is a very active member in OGSOK as well as in IMA Women's Wing, very actively participating and helps in organizing all the events. First person to come forward and help everyone. Over to you, ma'am. Please continue the session.
Thank you. It's been an honor to start the Journal Club of the year. I have put my efforts. Hope everybody gets take-home messages after this meeting. Okay. Today's my topic is WHO recommendations for intrapartum care for a positive childbirth experience. So, in spite of considerable debates and research that have been ongoing for several years, the concept of normality in labor and childbirth is not universal or standardized. Increasing medicalization of childbirth process tends to undermine the woman's own capability to give birth and negatively impacts her childbirth experience. In addition, the increasing use of labor interventions in the absence of clear indications continues to widen the health equity gap between high and low resource settings. This guideline addresses these issues by identifying the most common practice used throughout labor to establish norms for good practice for the conduct of uncomplicated labor and childbirth. The guideline recognizes a positive childbirth experience as a significant endpoint for all women undergoing labor. It defines a positive childbirth experience as one that fulfills or exceeds a woman's prior personal and socio-cultural beliefs and expectations, including giving birth to a healthy baby in a clinically and psychologically safe environment with continuity of practical and emotional support from a birth companion and kind clinical staff. So what are the recommendations? The WHO technical consultations led to 56 recommendations on intrapartum care. 26 of these are newly developed recommendations and 30 are recommendations integrated from existing WHO guidelines. So today I'll be talking about these 56 recommendations by WHO. The first one, hope this slide is clear or I'll change it. Okay, I'll start. So the first recommendation is for care throughout labor and birth. It's for respectful maternity care, RMC. Respectful maternity care, which refers to care organized and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth is recommended. Give me 5 minutes. I've gone to another slide which shows clarity. So this is main point for this is a new recommendation where we have to respect the mother's present situation.
Sorry to interrupt, ma'am. We can't see the slides which you are telling, ma'am. We can see the old slides only. Can you please stop share and share once again?
Okay, wait.
Yeah.
No share. Stop sharing. Okay, now it's been visible.
Yes, ma'am. Now visible, ma'am.
Okay. The first point is respectful maternity care, and it's highly recommended. The second one is for effective communication between mother and the clinical staff available in the labor room. So it's effective communication between maternity care providers and women in labor using simple and culturally acceptable methods is recommended. The third point is companionship during labor and childbirth. A companion of choice is recommended for all women throughout labor and childbirth. This is highly recommended. The continuity of care, wherever midwife is available, we can use. So they are telling midwife-led continuity of care models in which a known midwife or small group of known midwives supports a woman throughout the antenatal, intrapartum, and postnatal continuum are recommended for pregnant women in settings well-functioning midwifery programs. This is only context-specific recommendations, means where midwives are well-trained, they can be used. So it's the first 4 recommendations. Next, coming to first stage of labor. So definition has been slightly changed by before. The first one is definition. The use of following definitions for latent and active first stage of labor is recommended for practice. The latent first stage is a period of time characterized by painful uterine contractions and variable changes of cervix, including some degree of effacement and slower progression of dilatation up to 5 cm for first and subsequent labors. The active first stage is a period of time characterized by regular painful uterine contractions, a substantial degree of cervical effacement, and a more rapid cervical dilatation from 5 cm to full dilatation for first and subsequent labors. So the definition is latent first stage and active first stage. Up to 5 cm they have taken now. We have to follow this. So during first stage of labor, women should be informed that the standard duration of latent first stage has not been established and can vary widely from one woman to another. However, the duration of active first stage from 5 cm until full cervical dilatation usually does not exceed beyond 12 hours in primigravidas and usually does not exceed beyond 10 hours in multi. So the progress of first stage of labor for pregnant women with spontaneous labor onset, the cervical dilatation rate threshold of 1 cm per hour during active first stage is inaccurate to identify women at risk of adverse birth outcomes and is therefore not recommended for this purpose. If she is even slower, less than 1 cm per hour, she is progressing with good maternal and fetal conditions, we can wait. So we should not strictly follow 1 centimeter per hour in active first stage of labor. A minimum cervical dilatation rate of 1 centimeter per hour throughout active first stage is unrealistically fast for some women and is therefore not recommended for identification of normal labor progression. A slower than 1 centimeter per hour cervical dilatation rates alone should not be a routine indication for obstetric intervention. But in low resource setting, the partograph where it tells 1 centimeter per hour can be followed for triaging the woman in labor. If the woman is progressing slower than 1 centimeter per hour, they can take a decision to refer her to higher centers in a low resource settings. So labor may not naturally accelerate until a cervix dilatation threshold of 5 centimeters reach. Therefore, the use of medical interventions to accelerate labor and birth, such as oxytocin augmentation at cesarean section, before this threshold is not recommended, provided fetal and maternal conditions are reassuring. So next is labor ward admission policy. The 10th recommendation is for healthy pregnant women presenting in spontaneous labor, a policy of delaying labor ward admissions until active first stage is recommended only in context of rigorous research. Means we can admit her in maternity ward. We need not avoid her admission until she goes into active stage. We can promote admission. The 11th recommendation is routine clinical pelvimetry on admission in labor is not recommended for healthy pregnant women. So routinely clinical pelvimetry should not be done. It's not recommended to do clinical pelvimetry, but on admission, we can generally assess the pelvic condition to know the station of the head and amniotic membrane condition, other things to be noted, we can do. The 12th recommendation is routine CTG is not recommended for assessment of fetal well-being on labor admissions in healthy pregnant women presenting in spontaneous labor. Auscultation using Doppler ultrasound device or Pinard fetal stethoscope is recommended for assessment of fetal well-being on labor admissions. So routine CTG, continuous CTG is not recommended if in spontaneous labor in not low risk pregnant women. Only auscultation that in latent stage, like every 15 to 30 minutes, active stage every 5 minutes we can assess her in second stage of labor. So 14th recommendation is routine perineal pubic shaving prior to giving vaginal birth also is not recommended. It only is option for the mother if she wants to shave or clean her external genitalia, and we have to give her option by whom she wants to get it done. It is allowed. Otherwise, it is not routinely recommend to shave prior vaginal birth. So the 15th recommendation, administration of enema for reducing the use of labor augmentation is not recommended. So by giving enema, we are not going to cut short any labor stage or length of labor. So it is routinely not recommended as it is an invasive procedure and little cumbersome to the pregnant woman. The 16th point is digital vaginal examination at intervals of 4 hours is recommended for routine assessment of active first stage of labor in low risk women. So every 4 hours we can assess, or depending on the lady's condition, we can pregnant woman's condition, we can cut short. Continuous CTG is not recommended for assessment of fetal well-being in healthy pregnant women undergoing spontaneous labor. This is also same thing. There is no need to tie down the patient to continuous CTG as it is uncomfortable to the mother. We can mobilize her only by auscultation only. We can assess fetal condition well. The 18th recommendation is intermittent auscultation of fetal heart rate with either a Doppler ultrasound device or stethoscope is recommended for healthy pregnant women in labor. These all are conditions are mainly for low risk pregnant women. So the 19th epidural analgesia is recommended for healthy pregnant women requesting for pain relief during labor depending on women's preferences. So we can give an informed choice to the patient about the pain relief methods like epidural analgesia or opioids. Whichever she prefers, it can be given. It is recommended. So the 20th point is parenteral opioids such as fentanyl, dimorphine, pethidine are recommended options for healthy pregnant women requesting pain relief during labor, depending on women's preferences. But we have to inform the side effects of opioids like nausea, vomiting associated with it. But there is no study showing that it causes fetal depression, respiratory depression is there. So it is recommended if she is willing to go for opioid pain relief methods. The 21 recommendation is relaxation techniques including progressive muscle relaxation like breathing, music, mindfulness and other techniques are recommended for healthy pregnant women requesting pain relief during labor depending on women's preferences. So the environment inside the labor room to relax mothers in labor is highly recommended. Manual techniques such as massage application of warm packs are recommended for healthy pregnant women requesting pain relief during labor depending on women's preferences. The 23rd recommendation is pain relief for preventing delay and reducing the use of augmentation in labor is not recommended. This is not recommended. So for pain relief for delay in the labor process or for using of augmentation in labor, it is not recommended. For women at low risk, oral fluids and food intake during labor is highly recommended. So we can mobilize the patient, ask her to take oral fluids or food of her choice in lighter amounts during labor process. In their studies conducted, no issues of Mendelssohn syndrome like vomiting, aspiration has been recorded. So we can give oral fluids to labor patient. The 25th recommendation is encouraging the adoption of mobility and an upright position during labor in women at low risk is recommended. So we have to mobilize the woman. We need not restrict her to the bed. The 26th recommendation is routine vaginal cleansing with chlorhexidine during labor for the purpose of preventing infection morbidities is not recommended. We need not give vaginal douche regularly to all labor patients to avoid infection. 27th recommendation is package of care for active management of labor for prevention of delay in the labor is not recommended. The 28th is the use of amniotomy alone for preventing of delay in labor is not recommended. So early rupture of membranes is not recommended to cut short the labor stage. The 29th is the use of early amniotomy with early oxytocin augmentation for prevention of delay in labor is not recommended. So we need not augment any labor process by using oxytocin. The use of oxytocin for prevention of delay in labor in women receiving epidural analgesia is not recommended. The 31st guideline is the use of antispasmodic agents for prevention of delay in labor is also not recommended. Buscopan, epidocin, we need not give the patient so that there will be, it will prevent delay in the labor. There is no recommendation for those things. The 32nd is the use of intravenous fluid with the aim of shortening the duration of labor is also not recommended. So we need not oral fluids diet only is enough. We need not give IV fluids for low risk patients. They mean by giving IV fluids, when we need to start on oxytocin, the fluid overload might be a reason. The 33rd recommendation is the use of following definition and duration of second stage of labor is recommended for practice. The second stage is this is the definition for second stage of labor. The second stage is a period of time between full cervical dilatation and birth of the baby, during which the woman has an involuntary urge to bear down as a result of expulsive uterine contractions. So from full cervical dilatation with an urge to bear down till delivery of the baby, it's a second stage of labor. So women should be informed that duration of the second stage varies from one woman to another. In first labors, birth is usually completed within 3 hours. So we can wait till 3 hours from full cervical dilatation till delivery if maternal and fetal conditions are stable. Whereas in subsequent, like multigravida, it is usually completed within 2 hours. So this is recommended. The 34th recommendation is for women without epidural analgesia, encouraging the adoption of a birth position of individual woman's choice, including upright position, is recommended. So the birth position also, it's according to the woman's need. If she wants to deliver in upright position, she can, but we have to inform her the risk of vaginal tears, perineal tear, and if there is a need, so we have to counsel her to go into recumbent position. 35th recommendation is for women with epidural analgesia, encouraging the adoption of birth position of the individual woman's choice, including upright position, is recommended. But in epidural analgesia, usually there will be a neurotaxia, but nowadays they're using low dose epidural analgesia, so they can mobilize. But if she is willing to deliver in upright position, we can encourage at least for all 4 position, or we can counsel her for fetal monitoring, we can go for recumbent position. So the 36th recommendation is women in expulsive phase of second stage of labor should be encouraged and supported to follow their own urge to push. We should only ask her if she is feeling like to push, she has to push. We need not force her to push the baby out. If she has no urge to push, we can wait. As a guideline says, we can wait until 3 hours and primary and 2 hours for multi. So 37th recommendation is for women with epidural analgesia and second stage of labor, delaying pushing for 1 to 2 hours after full dilatation or until the woman regains the sensory urge to bear down is recommended in the context where resources are available for longer stay in second stage and perinatal hypoxia can be adequately assessed and managed. So this is for tertiary care center where there is good NICU facilities. We can allow her to bear down on her own. If in low resource settings, it is better to refer or use other methods for delivery. So the 38th recommendation is for women in the second stage of labor, techniques to reduce perineal trauma and facilitate spontaneous birth, including perineal massage, warm compresses, and hands-on guarding for perineum are recommended based on women's preferences and available options. The 39th recommendation is routine or liberal use of episiotomy is not recommended for women undergoing spontaneous vaginal birth. We should cut short using episiotomy for all patients. We have to assess only in the need we have to give episiotomy. It's highly not recommended. Liberal use of episiotomy is not highly recommended. We have to take informed consent before giving episiotomy to the mother. The 4th recommendation is application of manual fundal pressure to facilitate childbirth during second stage of labor is also not recommended. So manual fundal pressure is not recommended, but the study is going for gentle assisted pushing. Still the results are not come. Okay, coming to 41st recommendation, another 16 only are there. The use of uterotonics for prevention of PPH during third stage of labor is highly recommended for all births. So uterotonics, the main one is oxytocin, 10 units IM or IV is recommended uterotonic drug for prevention of PPH. In absence of oxytocin, in settings where oxytocin is unavailable, the use of other injectables like ergometrin, combination of ergometrin with oxytocin or oral misoprostol 600 microgram is recommended. So oral misoprostol 600 microgram or ergot derivatives we can use in absence of oxytocin. So, but we have to promote using oxytocin only as the main drug after in the third stage of labor. So the 44th recommendation is delayed cord clamping. So not less than 1 minute. Within 1 minute, we should not clamp umbilical cord. We should at least allow 1 minute for the blood to transfer. It's recommended for improved maternal and infant health and nutritional outcomes. So more than 1 minute we have to. So delayed cord clamping is highly recommended. 45th recommendation is in settings where skilled birth attendants are available, control cord traction is recommended for vaginal births if the care provider and the parchment woman regards small reduction in the blood loss And small reduction in the duration of third stage of labor is important. Like if she is anemic patient, mildly anemic patient, so control cord traction can be given, and it should be by a trained skilled birth attendant. By giving control cord traction, studies show around 11 ml of blood can be controlled, mean prevented, blood loss can be prevented, and 6 minutes of the third stage of labor can be cut short. If they think it is very important, then they can go for control cord traction. The 46th recommendation is sustained uterine massage is not recommended as an intervention to prevent PPH in women who have received prophylactic oxytocin. So if we are given prophylactic oxytocin, we need not give continuous massage. Sustained uterine massage is not recommended. But intermittently, after delivery, we have to intermittently assess for the tone of the uterus. It will come in the next recommendation. So 47th recommendation is in neonates born through clear amniotic fluid who starts breathing on their own after birth, suctioning of mouth and nose should not be performed. So this is not recommended. Routine suctioning of neonates mouth and nose is not recommended. 48th recommendation is newborns without complication should be kept in skin-to-skin contact with their mother during the first hour after birth to prevent hypothermia and promote breastfeeding. So we have to promote skin-to-skin contact of neonate and the mother during the first hour after birth. This is highly recommended. The 49th recommendation is all newborns, including low birth weight babies who are able to breastfeed, should be put to the breast as soon as possible after birth when they are clinically stable and the mother and baby are ready. So even low birth weight baby which can latch on, we have to promote breastfeeding immediately. All newborns should be given 1 milligram of vitamin K intramuscularly after birth. That is after first hour by which the infant should be in a skin-to-skin contact with the mother and breastfeeding should be initiated. So after that 1 hour, we can give vitamin K 1 mg IM. The 51st recommendation is bathing should be delayed until 24 hours after birth. If this is not possible in cultural reasons, then bathing should be delayed for at least 6 hours. So appropriate clothing of the baby for ambient temperature is recommended. This means at least 1 to 2 layers of clothes more than the adults, and use of hats, caps, and mother and baby should not be separated, should stay in the same room for 24 hours a day. So we have to delay bathing at least for 24 hours. If it's not possible, at least for 6 hours. The last 5 recommendations. So postpartum abdominal uterine tone assessment for early identification of uterine atony is recommended for all women. So regular uterine tone assessment is highly recommended. So after they tell after 1 hour we have 15 minutes once we have to assess the tone of the uterus to recognize PPH, and we have to check all our vitals immediately after delivery. Immediately after delivery, you have to mainly check her blood pressure. If it is normal, then after 1 hour, we have to check blood pressure. Then if it's normal, within 6 hours, again, we have to check blood pressure and confirm she has passed urine. So 53rd recommendation is routine antibiotic prophylaxis is not recommended for women with uncomplicated vaginal birth. So we need not put all mothers on antibiotic prophylaxis, only if we suspect or if there is any febrile, if she is febrile or if there is any other coexisting cold cough, then we can go for antibiotic prophylaxis. So routine antibiotic prophylaxis is also not recommended for women with episiotomy. It's not that after all patients with episiotomy, we should not give antibiotic prophylaxis. Only when we suspect episiotomy wound infection, then we have to go for antibiotic prophylaxis. All postpartum women should have regular assessment of vaginal bleeding, uterine contraction, fundal height, temperature, and heart rate routinely during the first 24 hours, starting from first hour after birth. So blood pressure should be measured shortly after birth. If normal, second blood pressure measured should be taken within 6 hours. Urine void should be documented within 6 hours. This is recommended. The last recommendation by WHO is after an uncomplicated vaginal birth in healthcare facility, healthy mothers and newborns should receive care in the facility for at least 24 hours after birth. So we should not discharge mothers within 24 hours. At least for 24 hours, she should be in the care of us. So these are the 56 guidelines which WHO has recommended for intrapartum positive childbirth experience. Thank you. I asked my seniors to discuss about this and give me knowledge about the experience which they day-to-day experience.
Purni, it was a very well presented, documented, evidence-based discussion. But there are some that are not applicable, practically possible in our setup.
Yes, ma'am. Yes, ma'am.
So some of them, I don't agree that you don't need an antibiotic and that sitting and standing
Yes, ma'am.
posture,
Only
all
WHO
that is not
guidelines.
possible.
Yes.
Recommend position only. You can say left lateral and you can conduct some deliveries maybe in sims lateral position also, but
Yes.
definitely recumbent only.
Yes, ma'am.
I don't understand how anybody can sit and stand and unless they deliver in the bathroom. So that is the otherwise I think you've covered a very extensive topic.
W56
It's very
guidelines,
nice.
ma'am. Thank you, ma'am.
Madam, can I
Yeah. Whatever have
in
nicely presented.
the
Thank you, ma'am.
madam?
God bless you. Bye.
Thank you, ma'am.
Thank you.
Purnima, we had
Cholma.
seen that the workshop, no, we did in gestosis.
Yes, ma'am. Yes.
I think people who attended the workshop have all understood what these WHO guidelines are, and then yes, they do standing position, then the sitting
All
position,
four. Yes, ma'am.
and on all fours.
Yes,
And
ma'am.
then now they also have in cities where they have water baths
Water
for
bath.
delivery.
Yes, ma'am. Yes,
Yeah,
ma'am.
water bath for delivery. And I think
All those
Sushma
was
knows, no?
pain relief, ma'am. Pain relief. Water bathing
Yeah.
and no breathing
And
and for pain relief.
yeah, in Fernandez also they also have, like, this midwifery training where they've trained the nursing staff to be a birth accompaniment person.
Companion.
So yeah, birth attendant. So I think it's not possible for one of us doctors to sit through the delivery right through. So we need to train our team to be aware and knowledgeable about all these guidelines. And I think our staff also need to be trained with these guidelines, and they should be knowing when to tell us, and these are the guidelines, this is what is the time you have to call us, and all these things, so that there's a one-on-one monitoring for the patient, and you are also relaxed, and you know that the staff knows what to do. I think that's something we have to do. And yes, the newer generation all want a lot of differences. They don't want to be like before. So if we need to show the newer generation a little bit of change, we also have to unlearn and relearn a lot of things. This is my opinion.
Yes,
No,
ma'am.
madam. Initially, when I did DNB, even I was in the same school of thought, madam. But when I went to Fernandez, there a new thing opened where initially I was very afraid to go and deliver only because we should not give episiotomy there. But we have been taught to give episiotomy liberally. But we have to not give episiotomy. So I was initially very afraid to go and deliver the patients only. But after I saw 2-3 deliveries, how they are conducting, even if we don't give episiotomy in primary also, there will be very minimal tears, madam. But we should learn the techniques, how to give that support and when exactly to give that support. That if we learn, the tears will be very minimal, madam.
Yeah.
Yes, ma'am. Ma'am, the other thing is, I think it's all depends on at the time of delivery, the assessment of the baby's weight, all that
Correct.
matters. Because if you don't give a liberal episiotomy, we have seen paraurethral tears. We have seen, no, that is quite difficult sometimes to repair also. She may be
One
torrential.
main thing what I have noticed is we are not using epidural so much, madam. There
Correct.
90% of labor is epidural only, madam. So they will do controlled pushing because they won't have pain. But here it is not like that. Once we tell to push, they will push with full force. There is no controlled pushing here because we don't have epidural, madam. If we start giving epidural, maybe they will listen to us at that point of stage, madam. That is the only difference I have noted, madam. There 100 patients deliver, 90 will have epidural. So they will not have that urge to push, nothing. After full dilatation, we will not give epidural top-ups, madam. But they will listen to us patiently because they will not have that much pain. Here we can't expect that from non-epidural patients, madam. Once we
Correct.
tell like we push means they will push with full force so that the pain will be less after delivery. So that is the problem. That's why tears happen, madam. If we do controlled birth, no tears, madam. I was also very afraid to go into the labor room only initially, madam. One month I didn't go only, madam. If they tell me labor also, I was not going.
Any other comment?
No, ma'am, it was very nice actually going through the whole WHO recommendations. It was really nice that it was like going back to knowing the technique is really important for the present day practice. Good, well done job, and let the journal club keep continuing. We learn more from each other. Very good, well done, well done.
ma'am.
Sure, madam. Thank you, madam.
Yeah. Purnima,
Yes, ma'am.
very well done.
Thank
And
you,
I
ma'am.
think
Yes.
we've shared the guidelines with everybody. Everybody can read it who have not read
Yes.
it. It's there in the group, no?
Share in the group, madam.
Yeah.
Yeah.
We'll share the guidelines in the group.
Okay.
And also Chitra will share the recordings of the today's proceedings into the group also.
Okay.
Yeah.
Okay. 1 minute, ma'am. 1 minute, ma'am.
Yeah.
Radha ma'am has asked about the opioid analgesia, ma'am. That I'll just.
Pethidine, actually, we have to take 1 ml and dilute in 5 ml, madam. And that you can give 1 or 2 ml per time. That is once in
Per
3 to
dose.
4 hours, madam. Per dose, we can give 1 or 2
2
ml, madam. 1 pethidine vial should be diluted in 5 ml of normal saline or distilled water. And we have to keep the dilated one with label. Every 3 to 4 hours, we can use 1 or 2 ml according to the patient's need, madam. First, we have to explain that the epidural analgesia with opiates, it will decrease only by 40%, madam. 60% pain they will feel, they will experience. With epidural analgesia, there may be 80 to 100%, madam. Sometimes when it is in advanced labor and the head is low down, they may feel the push of the head even in epidural analgesia. But with pethidine, it is recommended only in first stage of labor, madam, where the delivery doesn't happen within 2 hours. So if we expect delivery within 2 hours, we should not give pethidine because that time the baby, when coming out, it may experience a respiratory depression.
Correct. See, epidural also, we need to have an anesthetist full time with us who
Yes,
can
madam.
monitor.
Yes, madam.
So we need to be extremely careful. If we have a person just coming and going and in between
No, madam,
monitoring,
we
that
have
is
to
not
because
going to happen. We should have an in-house full-time anesthetist to give epidural and monitor the patient. That's one thing. Second thing is, nowadays pethidine is not very freely available because of the narcotic
license.
licenses that are required. So if at all you're using pethidine, you have to be extremely careful about how much you are indenting, how much you are using, how are you keeping it. It should be under lock and key.
Double lock.
And the other thing is its availability to the other staff for misuse should be avoided. So in case there's an overdose of pethidine or some staff misuses of pethidine, it becomes a legal issue. You know, even the drug inspector, the local government bodies, everybody will jump at you like wolves, you know. And that is the end. It is another stressful, tragic event for all of us. So if at all you have indented pethidine, please see that it is under very strict monitoring. Dosages and number of vials to be kept in strict control, and not in the pharmacy, not in the OT, not in the labor room. It should be issued by one of responsible doctors, or only the anesthetist should have reached to that. I also like, see, this respectful maternal care, no, is something that all of us have to inculcate in our day-to-day practices. Recently, I mean, I had one patient who came and told me that, you know, they didn't like, one of their friends told them that they didn't like somebody, sorry, they didn't like somebody being yelled at, screamed at, or forced to, you know, spoken loudly. Spoken loudly too. So, you know, today that's what you need. They need to be pampered, they need to be cajoled, and then you need to say challam kutti, all these things to them, because even at home they've been brought up like that. They're all either one child or two children, and they don't know for an answer, and then they've been very comfortably, even to take an injection, the whole family is there with them, you know. So will she go through pain? Half of the reason why the normal deliveries are getting lesser is because of the anxiety of the parents for their daughter to go through the pain. So I think in this thing, we need to counsel the parents, the husband, get them into confidence and tell them that it's normal for any girl to go through this pain. and then they should support us as a team to allow them to go in for normal delivery. If in case they need any intervention, that we are always there to take care of it.
The heading only says it's a positive childbirth experience. So after that experience, they should feel positive.
Correct.
They had the capability to deliver a baby.
Yes, but then we'll all have a lot of sleepless nights.
Yes. When we have individual practice, it is very difficult, madam. Like you told.
I think we should all move towards group practice further, especially in maternity care.
Yes,
Maybe
ma'am.
the remaining things become individual practice, but labor room should be like, group practice. I've seen a few of my friends who work together, and what they do is they admit all the patients in one hospital, and then on rotation, each of them take call on one day. And so the other 4-5 days, the rest of them are free. So I think somewhere down the lane, all of us should go into group maternity practice.
Yes, madam.
For the benefit of the patient and for us.
Yes.
Okay. Thank you, Purnima. Thank you, Sushma.
Thank you, ma'am. Thank you, ma'am.
Thank you, Chitrakala and Shield. I'd like to appreciate Balaji sir and Chitrakala for always supporting us just at a call away. And anytime you call and say they're just ready to do anything for us, thank you very, very much.
Thank you, ma'am. Thank you, ma'am.
Thank you so much, ma'am.